Welcome to the HIV and AIDS Care series. This is the final section in this series. We will begin with a very brief overview of evaluation and management coding, which was covered in Series 1. We will also review HIV testing and counseling codes, covered in Series 1A. We will also look at the ICD-9 codes, covered in Series 2, and modifiers was covered in Series 1 and 1A as well. Finally, we will end this series by looking at some coding scenarios which will encompass ICD-9 codes and evaluation and management and HIV testing and counseling codes all in one scenario, so that you have a better understanding of how to assign the codes for HIV and AIDS care. This slide is just a disclaimer. And the next slide provides an overview of the learning objectives. The first objective, as I indicated, is to review. We're going to look at CPT codes, your HCPCS codes, and your ICD-9 codes, which were learned in the other three series. We're going to look at some coding scenarios that will reflect accurate reporting of codes for HIV and AIDS medical care. We will also discuss the importance of proper code sequencing and discuss the importance of proper documentation and its impact on reimbursement. These are the acronyms that are used in the presentation. So let's begin with our overview of evaluation and management. This slide provides an overview of the preventive medicine new patient visit codes, which was covered in Series 1. So 99381 through 99387 are your new patient preventive medicine visit codes, also known as your annual exam and your well visit codes. Your established patient visit codes are for your patients who have been seen within a 3-year period. So your 99391 is younger than 1 year old, and 99397 is 65 years of age and older. The next set of codes are also evaluation and management, but these are your preventive medicine counseling and or risk factor reduction codes. These codes are used when there is a preventive counseling service without a history and physical exam. These codes are assigned based on the amount of time spent counseling the patient. So 99401 is 15 minutes, and all the way through 99404, which is 60 minutes. These codes are never used in conjunction with the preventive medicine visit codes. So this is something to make sure that you are aware of as far as when a patient comes in just for counseling, these are the codes that you would consider using. If the patient presents for counseling and they have a physical and a history, then you should utilize the codes on this slide. Your regular office visit codes, new patient visit 99201 through 99205 versus the established patient visit code 99211 through 99215. So just to reiterate, the new patient visit codes on this slide as well as on slide number 6, the distinction between new versus established is the same for both code sets. A new patient is one who has not been seen or evaluated by a physician within the same specialty, within the same group practice in the past 3 years. And an established patient is one who has been seen within a 3-year period by a physician in the same specialty or in the same group practice. So here is an overview of the codes based on the 3 key components that was discussed in Series 1, your history, your exam, and your medical decision making. So these codes also provide you an overview of time spent, and the time is not a determinant factor in selecting the codes. These codes are selected based on the components of history, an exam, and medical decision making. All new patients require all 3 of the components of a clinic visit, service, and an established patient visit requires two of the three components. The most critical component in an established patient visit would be your medical decision making. So the documentation should clearly reflect the medical decision making, which entails your diagnoses, your treatment options, and any referrals to a specialist if that's a service that was provided during the encounter. The HIV test codes are provided on this slide. You have your CPT codes, 86701, 86702, 86703, and 86689. And then you have your HCPCS code, G0435. These are your antibody codes. Your rapid HIV test codes are provided for you on this slide. So in the event that you, physician decides to perform a rapid HIV test, you would consider one of the codes that's listed here, G0435, 86701, 86702, or 86703. You have to check with your local Medicaid agency to find out which code set is appropriate, because some Medicaid agencies require the use of the G code, and some Medicaid agencies may require the use of one of the CPT codes. Your HIV antigen codes are listed for you on this slide. So you have your CPT codes, 87389, 87390, 91, 87534, 35, 36, 37, 38, 39, and then you have your two your two HCPCS codes, G0432 and G0435. These services are typically not considered the rapid. So in those instances when it's an HIV blood test, you would need to also use the routine venipuncture code 36415. So this code is used in conjunction with the codes on this slide when the HIV test is done by taking blood specimens. So some coding tips. The HIV Pre-Test with testing and preventive care, including counseling. These are your code sets for a new patient. And this is your code set for the established patient. For those services where it's just counseling without any history and physical exam, you would utilize one of the counseling codes, and it's based on the amount of time spent counseling the patient. Some coding tips. The HIV post-test counseling codes, 99401 through 99404. To reiterate, these are your time-based codes. Or you would utilize the established patient visit codes, 99211 through 99215. Your HIV post-test counseling with coordination of care for results that are positive is the same code set. So you would utilize a counseling code, and depending upon your Medicaid state agency, you may also be able to bill one of the established patient visit codes, 99211 through 99215. So in either instance, you should contact your local Medicaid state agency to determine which code set is the appropriate codes to use, because each Medicaid state agency has its own specific coding instructions that they require that you follow. Some additional coding tips. The HIV pre-test with testing and preventive care, including counseling. So you would report the applicable code for the test performed and modifiers, which was covered in Series 1 and 1A. So depending upon your local Medicaid agency, you would need to append a modifier 92 or a modifier QW. And I'm just checking to see if the modifiers are here. That should be the next set of slides. Yes, here we go. So your modifiers are here on slides 17, 18, and 19. So for the HIV test code, you would consider utilizing modifier QW, or you would utilize modifier 92, depending upon the guidance from your local Medicaid agency. And now let's go back to this slide we were just looking at. Okay, so some additional coding tips. I believe I skipped a slide. Nope, they're here. I apologize. So we were here. HIV counseling without testing. So again, report the appropriate HIV. Okay, so this slide has an error, and I apologize. So if the patient presents for counseling without any testing, you should be reporting one of the counseling codes, 99401 through 99404. So let's do this here. 99401 to 99404, based on the amount of time spent counseling the patient. So this information is an error. All right, so just to reiterate, if the patient presents for HIV counseling where there's no testing and there's no preventive care, utilize one of the counseling codes. Counseling is based on the amount of time spent counseling the member or the patient. The codes for the HIV test itself, T codes 87389, is inclusive of the HIV-1 and the HIV-2 test, as well as the HIV antigen test. So if the patient has an HIV-1 and an HIV-2 test on the same day, and the local Medicaid agency requires that you report the CPT codes, then you only report 87389. If your local Medicaid agency requires that you report the G codes in lieu of the CPT codes, then you would defer to one of the G codes, G0432, G0433, G0434, or G0435, which were found on the previous slide. So the modifiers are only used when the circumstance indicates that there was an additional service performed together in the same session. And we will look at some examples of when it's appropriate to use a modifier versus when you should not use a modifier. The modifier 25 is only appended to the E&M codes. And so again, we will look at some examples in some slides that are coming up shortly. So your modifier 25 is only used on the E&M service codes 99201 through 99215. You should not be reporting this modifier with any other CPT code other than evaluation and management. This modifier is not used on any HCPCS codes. So your HCPCS codes are your G codes, and you would not append this modifier to any of the G codes. Contact your local Medicaid agency because not all state agencies require the use of a modifier 25. So if the guidance from your Medicaid agency is specific and they indicate that you do not need the modifier, then it is not necessary to report, to append the modifier. Modifier 92 describes the HIV test code. So this modifier is only used on the CPT codes 86701 through 86703. This modifier is not used on any other tests. It should never be appended to any HCPCS codes. So again, your HCPCS codes are your G codes. You should follow up with your local Medicaid agency to find out if they want you to use modifier 92 or if they want you to use the other modifier, which we will be looking at momentarily on your next slide, which is modifier QW. So you have a choice between modifier QW or modifier 92, dependent upon your local Medicaid agency. Modifier QW is appropriate for CPT codes as well as for HCPCS codes. But these are the only codes that this modifier can be appended to. So it should not be appended to any other code types. And an example would be 99201 through 99215. So this modifier would never be appended to any of the E&M visit codes. Apologize. In the instance of a provider making the decision to perform a waived HIV test and a non-waived test together during the same encounter, you would not use a modifier. So you would just report the waived test in lieu of any types of modifiers. But in the interim, you should still consider contacting your local Medicaid agency because they may have some other specific coding guidance or specific coding instructions that you may have to follow. The ICD-9 codes describe the patient's medical condition or the reason for the visit. So V0179 is the diagnosis code for exposure to AIDS or HIV, and it is also used for pre-exposure. V67.9 is follow-up exam. V69.2 is high-risk sexual behavior. V69.8 is other problems related to lifestyle. This code is also used for asymptomatic high risk, and it's also important to note that this code would never be reported as the principal diagnosis or the first listed diagnosis. This code is only reported as a secondary diagnosis to another diagnosis that would be listed as the principal. Your V70 is the code for a routine general medical exam, also known as the well visit. So for any services where a patient presents for an HIV test and they also have a well visit during that encounter, the V70.0 would always be sequenced as the principal diagnosis, and any of the diagnoses, for example, for HIV counseling would be considered a secondary diagnosis. Or if they have an HIV test during the exam, the V73.89 would be reported, but it would be reported as the secondary diagnosis, and the well visit diagnosis would be the principal diagnosis. Some other diagnosis codes. V08 is the symptomatic HIV. This code is also used for an HIV positive or an HIV positive status. We already looked at the HIV counseling code, V65.40. 042 is the diagnosis code for HIV disease. Some synonyms for this is AIDS, AIDS-like syndrome, AIDS-related complex, symptomatic HIV infection, or HIV-1. In some instances, a patient may be diagnosed as HIV-1 and HIV-2. And in those instances, you would report two codes. The 042 would be designated as the principal diagnosis, and it would be used to report the HIV-1 condition. And 079.53 is the HIV-2 diagnosis, and this would be reported as the secondary diagnosis. This code is never reported by itself, and this code is never reported as the principal diagnosis. 079.53 is only a secondary diagnosis, and it can only be reported with 042. The last code on this slide is 795.71, non-specific evidence of HIV, also known as inconclusive HIV testing. So in those instances when a patient has a diagnosis that cannot be determined as positive or it's undetermined, the appropriate diagnosis code would be 795.71. Here's some additional information about the inconclusive HIV test. Newborn babies born to HIV-positive mothers oftentimes have a diagnosis of HIV positive because of the mother's antibody. So in those instances, the patient or the newborn baby's result is inconclusive, or it's also known as a false positive. And so, to reiterate, the diagnosis for inconclusive or false positive is 795.71. We also covered in Series 2 the opportunistic infections, where we spoke about people who have healthy immune systems and that they can be exposed to certain viruses, bacteria, and that we have people that are living with HIV and AIDS that are susceptible to catching various infections. So it's important to keep in mind that for any patients that have any of the opportunistic infections, that these patients should have a principal diagnosis of 042, and then any of the diagnoses for the opportunistic infection would be sequenced as the secondary diagnosis. So on this slide, we just have an example or some examples of the most common opportunistic infections. And for a full complete list, visit the CDC's webpage. For a full complete list, visit the CDC's webpage. But this is just a short list of the most common opportunistic infections. So some ICD-9 coding tips that we should keep in mind. The coding guidelines dictate that the following terms apply to the diagnosis of HIV infection: acquired immune deficiency syndrome, acquired immunodeficiency syndrome, AIDS, AIDS-like syndrome, AIDS-related complex, HIV infection, and HIV-1. And so it's important to keep in mind that this code 042 is only used for confirmed cases of AIDS or HIV infection. If a patient's medical record states that that the diagnosis is possible, probable, rule out, or suspicion of, you should never be using a diagnosis of 042. The most appropriate diagnosis would be inconclusive, 795.71. So if you go back to the slide that shows the summary of the diagnosis codes, you will see the Inconclusive HIV Test Code, 795.71. Some additional coding tips: a diagnosis of HIV positive and asymptomatic HIV should be coded as V08, and it is not the same as a diagnosis of HIV infection and should never be coded as 042. So to reiterate, a patient that has been diagnosed with AIDS or the HIV infection, the diagnosis is 042, versus a patient that is HIV positive or HIV positive status or symptomatic HIV, the diagnosis is V08. It's important to remember that once a patient becomes diagnosed with the HIV infection, the diagnosis code that should be reported on their health record is always going to be 042. You would never defer back to a diagnosis of 08. We also covered the symptomatic HIV versus inconclusive HIV. All right, so anytime a patient has a diagnosis of 042, you would never report a symptomatic HIV, B08 is that code, and you would never report inconclusive HIV, 795.71 is this code. So some more coding tips here on the last bullet. If the health record documentation states that the patient has HIV positive, but it has not been diagnosed with any of the HIV-related conditions in the past or the present, assign B08. If the patient's record says that they are HIV asymptomatic, but they're being treated for any of the HIV-related conditions, this patient has a confirmed diagnosis of AIDS, and the diagnosis that should be reported is diagnosis code 042. So some additional coding tips. The HIV-2 infection code that we discussed should only be reported as a secondary diagnosis. The principal diagnosis is always going to be 042. So this is your principal diagnosis, and this is your secondary diagnosis. The inconclusive or nonspecific diagnosis, again, is 795.71, and this code is typically assigned as an additional diagnosis, and it's typically never, reported as a principal. Some additional codes to keep in mind: exposure to or pre-exposure, V01.79. And again, this is a code that is never reported as the principal diagnosis. And just to make sure that everyone understands the acronyms on this slide, please remember the acronyms, the summary of the acronyms used in this slide are at the very beginning. PDX stands for principal diagnosis, DX stands for diagnosis, and SDX stands for secondary diagnosis. So V01.79 is a secondary diagnosis. It should never be reported as a principal diagnosis. It's only reported as a secondary diagnosis. So any of the codes on this slide that contains an asterisk is a code that is designated as a secondary diagnosis code only. And in the instance when the code is reported, it would never be reported alone, and it would never be reported as a principal diagnosis. Some additional codes that can be reported on claims is high-risk behavior, V69.8. Patients that present for well-visited encounters and also have HIV testing and counseling during the encounter, you have your V70.0 and your V65.44. For patients that present for HIV testing and counseling, V73.89 and V65.44. So some additional tips. We've already discussed that opportunistic infections are only reported with the HIV infection code, and that the opportunistic infection diagnoses are always reported as the secondary code. Your next slide. Code sequencing is very, very important to the coding process. If the codes are sequenced in the wrong order, this could result in denial of your claims. So in those instances when there is multiple diagnoses reported on a claim, you have to make sure that the codes that are designated as principal diagnoses are reported as the first listed code, and the codes that are reported as a secondary diagnosis are reported only as a secondary diagnosis. Just to reiterate, the OI infection codes are always secondary, and the HIV-2 code, 079.83, is always a secondary diagnosis code. So the next couple of slides are some case studies that provide some coding examples. So the first case study is an HIV counseling without testing. 17-year-old patient presents to her GYN to discuss contraceptive options and safe sex. So the doctor spends 45 minutes counseling the patient, and since the patient declined an HIV screening test and the physician only counseled the patient, the appropriate code in this instance is your office visit counseling code, 99403, because it reflects 45 minutes of counseling, along with the diagnosis code of counseling, V65.44. So this next slide provides the rationale for the codes that are presented in this case study. So if we go back to slides 6 through 9, you'll find the CP codes for counseling. So let's just take a quick look back at slide number 6. So these are your preventive medicine visits that include counseling, and these are your preventive medicine visits for counseling only. So since the physician spent 45 minutes counseling the patient, the correct code in this instance was 99403. So let's go back. That was 22. Oops, I'm sorry. Give me 1 second. I think that was 31. Yeah, no. Okay, so the rationale for case study number 1, as we were reviewing, since the patient did not have a history or an exam, the final E&M code was the 99403. The diagnosis code for counseling is V65.44. Since there was no mention of high risk in this case, we decided not to use the high risk diagnosis. So case study number 2 is HIV Pre-Testing with Preventive Care. So this is a 27-year-old patient that presents to the primary care physician's office after having unprotected sex, and the patient requests an HIV test. Since this was a new patient, the physician decided to do a full preventive medicine visit exam along with counseling the patient and performing a rapid HIV test. So here in this example, you see the use of modifiers. Because the patient presented for concerns about having unprotected sex and requested an HIV test, we have our test code, and the physician made the decision during this testing to perform a well visit. So the well visit requires the use of a modifier. The modifier 25 tells the payer that during the HIV testing encounter, the physician made the decision to perform a well visit. And so this modifier is only appended to the well visit series. Depending upon your local Medicaid agency, you will append a modifier 92 or a modifier QW. Or if they tell you not to use a modifier, then you would defer and not use a modifier at all. So now let's look at the diagnosis codes for this case study. Because the patient presented for a well visit, because the physician made the decision to perform a well visit, in this instance, the E&M service well visit code is the first listed procedure code, or E&M code, and we have to link the diagnosis for a well visit to the CPT code for a well visit. And that's the reason why this V70.0 is listed or sequenced as the principal diagnosis. The HIV screening code is here, V73.89. We have the HIV counseling code, V65.44. And because the documentation states that the patient had unprotected sex, we made the decision to also report the high-risk behavior code, V69.2. Your HIV test code, the diagnoses are different, as you can see. The V70.0 would not be reported with this test code because it does not support medical necessity. And so if you were to report the V70.0 as the principal diagnosis with the HIV test code, it would cause your claim to reject. So in this instance, if you notice, there are only 3 diagnosis codes. You have the screening code, you have the counseling code, and you have your high-risk behavior code. And the next slide provides the rationale, which I just explained. Slide. So this is a general medical exam, also known as a well visit. So we reported the well visit for a new patient encounter. Because the well visit, because the new patient as well as the established patient well visit codes also include counseling, we did not report a separate counseling code in this instance. This is a rapid HIV test that was performed. So the most appropriate code in this instance is 86701. So check with your local Medicaid agency because they may require the use of the G codes, which we discussed in prior slides. But this is the most common the most commonly used code by most of the local Medicaid agencies. Both of the codes reported, the 99385 as well as the 86701, required the use of a modifier. So the modifier 25 was appended to the CPT code 99381, and the modifier 92 or QC would be appended to the test code depending on your local Medicaid agency. The diagnosis code rationale is explained on this slide. Excuse me. The physician performs a well visit, B70.0, and what we said is that this code is only reported with the well visit CPT code. It is not reported with the HIV test code. And then you have your B7389, B65.44, and B69.2. And all three of these codes are reported with both the test code as well as the well visit E&M code. The third example is an HIV pre-testing with preventive medicine, and this is an established patient. And so since this is similar to the previous example, the only difference is this is an established patient. We're not going to spend a lot of time on this encounter. So this patient has been seen by the physician before. The rationale here for reporting the 99395, because there was a test and an E&M performed on the same day, we had to use the modifier 25 for the E&M visit, and depending upon your local Medicaid agency, you would utilize the 92 or the QW. So let's go to the next example. HIV post-test counseling with negative results. So the patient returns for their test results, and the physician advises the patient that the results are negative and spends 30 minutes counseling the patient. So again, in this instance, the counseling codes are selected based on the amount of time spent counseling the patient, 99402. Your diagnosis code for counseling is B65.44, and this is a patient with a high-risk behavior, so in this case, we also reported B69.2. Now, it is not necessary to report B69.2, but for the purposes of the patient's behavior, I would suggest or strongly urge that you report the high-risk behavior code. The next slide provides the rationale for the code selected in this scenario. So you have, and so there is an error here. This code should not be here because this code reflects a patient that presents for a follow-up well visit. And in this particular encounter, we stated that this is an HIV post-test counseling visit only. So the correct code for this HIV post-test counseling only is 99402. The diagnosis codes that are listed, B65.44 and B69.2, accurately reflect the counseling component and the high-risk sexual behavior component, and these are the only two codes that are necessary for this encounter. The next two sets of examples are for HIV post-testing, HIV post-test counseling, positive results. So the first case study will focus on asymptomatic positive results, and the next example will be symptomatic positive results. So let's look at the asymptomatic positive results case study. This is a patient that returns for their HIV test results, and the physician advises the patient that they are HIV positive. He counsels the patient and explains what it means to have a diagnosis of HIV positive versus the actual HIV infection. The physician also counsels on the proper use of medication, implements a treatment plan, and advises the patient to return in 3 months for a retest. So we've already mentioned that this is an established patient, and The documentation in the chart reflects a problem. What does it say here? I'm sorry, give me 1 second. Let's go back. The CPP, or rather I should say the E&M code selected in this instance is selected on the basis of the history, the exam, and the medical decision making. And so in this case, we selected a 99213. The diagnoses that are reported are V08 and V65.44. The V08 is a confirmed diagnosis of HIV positive, and the V65.44 designates the counseling status. So this is the rationale for the codes that are selected in the previous slide. This is considered a sick visit encounter because the patient has a confirmed diagnosis. Prescriptions are dispensed. Documentation is, the information is documented in the record. The components are an expanded problem-focused history, an expanded problem-focused exam, and the medical decision-making is low. So the final E&M level in this case is a 99213. And your next slide provides you the diagnosis rationale. So V08 is HIV positive, and V65 is the counseling code. The next slide, as discussed, is HIV post-test counseling, where the patient has positive results, symptomatic AIDS. So in this instance, the patient returns for their test results, and the physician advises the patient that they have the HIV infection. The physician counsels the patient and explains in detail what the HIV infection is, implements a treatment plan, discusses the treatment plan with the patient, along with discussion about the importance of taking your medication and the importance of practicing safe sex at all times. So in this case, this is an established patient. So again, we're using the established patient E&M level, 99213. The patient has a confirmed diagnosis of AIDS, 042. The documentation states that the patient was counseled, V65.44. And in this instance, you can also use the high-risk behavior, which is not listed here, V69.2. So because the physician also mentions the importance of practicing safe sex, they can utilize the V69.2 as the third diagnosis. It's just an option. It's not mandatory, but again, I suggest that you utilize it because it helps to tell the payer that the patient has a high risk of sexual behavior. So here's the rationale for case study number 6. The selection of 99213 is explained here based on the history, exam, and level of decision-making, which was all documented in the patient's record. The diagnoses are also explained here. 042 is the principal diagnosis, and V65.44 is the secondary diagnosis. Now, just as an example for this scenario, as well as for the prior scenarios, in the case where a patient has a confirmed diagnosis, where counseling is also involved, the counseling code would never be sequenced as the principal diagnosis for a patient that has a confirmed medical condition of HIV or HIV positive or AIDS. So in this instance, the sequence that you see here is the correct sequence, and it should be followed at all times. The same applies if you go back to the previous case study, the 042 and V65.44. The same applies if you go back to the prior case study. Here we go. V08 would always be sequenced as the principal diagnosis, and then V65.44 would always be sequenced as the secondary diagnosis. As we mentioned, sequencing is critical to the coding process. If the codes are not sequenced properly, the local Medicaid payer may make the decision to deny your claim. So you want to make sure that your codes are always sequenced based on correct coding guidelines, as well as based on guidance from your local Medicaid agency. So here's another HIV post-test counseling example. In this example, the patient is diagnosed with HIV-1 and HIV-2. So this is an established patient, 99213. The diagnoses for the patient who has been diagnosed with HIV-1 and HIV-2 is 042, 079.53, and V65.44. And so again, to reinforce the importance of sequencing, 079.53, which is the code for HIV-2, would never be sequenced as the principal diagnosis. It is only the secondary diagnosis, and this code is only used with 042, which is the diagnosis for HIV-1. The rationale for the codes selected in the prior slide. So 99213, based on the documentation that's in the chart, which includes a history, exam, and medical decision-making. The diagnoses that are reflected in the prior slide. So 042 and 079.53 reflect the HIV-1 and the HIV-2. We already stated the importance of sequencing. So 042 is always the principal diagnosis, and 079.53 is always the secondary diagnosis when reported together. We stated that 07953 is never reported alone. The third diagnosis in this scenario is the counseling, V65.44. And additionally, you could also report V69.2, high-risk sex behavior. The next example is antiretroviral therapy for a newborn patient. An HIV-positive mom brings her 2-month-old to the pediatrician's office, and the pediatrician documents an expanded problem focus history and performs a brief exam. After the lab results were reviewed, the physician made the decision to change the medication and also revise the treatment plan and asked the mom to bring the baby back in 1 month. So here again, we have a patient that has a confirmed diagnosis of inconclusive HIV, and 795.71, it's inconclusive HIV test results, 795.71. Pre-exposure to prophylaxis is the appropriate secondary diagnosis, as this diagnosis code describes the baby having the mother's HIV positive status, as opposed to what we stated in the diagnosis series, was that typically the babies have are diagnosed with the mom's condition. Their diagnosis reflects the mom's condition, and not necessarily that the newborn has a diagnosis of HIV or AIDS. And so this is the rationale for the V01.79, the pre-exposure prophylaxis. And because this is an established patient, 99213 is the appropriate code. We know that it's an established patient because the documentation says that it's an antiretroviral follow-up for the 2-month-old. The next case study provides the rationale. And so again, 99213 is an established patient visit code selected based on the documentation. We stated that this is a sick visit encounter, and it's a sick visit encounter based on the diagnoses of inconclusive HIV test and pre-exposure prophylaxis. And to reiterate, the sequencing is still important in this scenario. You would never sequence pre-exposure prophylaxis as the principal diagnosis. This is always the secondary diagnosis in this example. We indicated that the false positive diagnosis in the newborn could last for up to 18 months. So for the next 18 months during the patient's care, this sequence would more than likely be the code sequence that would be utilized on the patient's chart. So why is documentation considered important? It's important that the medical record documentation support any claims that are submitted to the local Medicaid agency. In those instances where the charts do not coincide with the billing, the local Medicaid agency may make the decision to recoup monies, and in some instances, there could be heavy sanctions. So it's very important that the documentation coincide with the claim that is submitted to the Medicaid agency. The documentation should clearly reflect the diagnoses that are being treated. It should also reflect the rationale for the E&M level that was selected. If there were any diagnostic tests, such as an HIV test, that should also be clearly reflected. And in those instances when there is a well-visit encounter and a test, the documentation should clearly reflect that, because that would be the rationale for utilizing a modifier when you submit your claim. So all of this is critical to the billing process, and it is important to make sure that your documentation reflects the rationale for any claims that are submitted. Just to go back, any type of documentation inaccuracies could result in payment recoveries and heavy sanctions. And when there is a consistent level of inaccuracies, the decision to restrict or exclude a provider or sometimes terminate a provider is made by the Medicaid Inspector General. So it's important to have someone do an audit of the records to make sure that if there are any training issues that need to be ironed out, that you document that training is provided and that you show evidence to support that your training is designed to reduce documentation and coding inaccuracies. So this slide just basically gives you a flow chart of complete documentation, correct coding, appropriate reimbursement from the local Medicaid agency. The last three slides just provide you an overview of the supplemental web resources that were used to prepare this coding webinar series. And if you go to the resource document that was prepared for you, there is a table of contents that provides a summary of all of the content that is found in the webinar series. So in your resource document, it covers CPT coding, which breaks down into evaluation and management, the preventive medicine visit codes, and modifiers. It also covers your ICD-9 codes. Modifiers is covered in some level of detail on page 14. The summary of codes used in this webinar series is on pages 14 through 18. And then again, the last couple of pages in the web resource document provides all of the coding resources used in the presentation, all of the web resources used in the presentation, and a complete list of the state Medicaid agencies so that you can contact them for further instructions or for coding guidance. There is an additional, let's go back here. There also, for your convenience, there is a, where is it? There is a company that provides little charts of, what is it called? I'm sorry. Cheat sheet. I apologize. So there's a company that provides cheat sheets that provides a summary of the commonly used diagnoses that you can keep in your pocket. So it's also called a pocket guide. So for your convenience, you can also check with Ingenix for the Fast Finder sheet, or you can also check with the American Medical Association. There are other resources that are out there that can be utilized for coding support, such as the American Academy of Professional Coders, the American Health Information Management Association, and the American Academy of Family Physicians is also a resource that can be used for physicians. And last but not least, American Hospital Association. So this concludes our HIV and AIDS Care series. Thank you for attending.